I'd like to wish a very good afternoon and a very warm welcome to all present here. At the very start, I would like to invite our chief guest, Emeritus Chairperson Dr. M.L. Swarankar sir, our International Faculty for International Speaker Program, Dr. Prapagaran Narayanan sir, our guest of honor, Chairperson Dr. Vikas Swarankar sir, our special guest, Vice Chancellor Sir Dr. Sudhir Sachdev sir, special guest Pro Vice Chancellor Dr. G.N. Saxena sir. To preside this session, I would like to invite our Principal Ma'am Dr. Swati Garg and our HOD Dr. Tarun Ojha sir. Kindly take your seat on this stage. Thank you sir. Thank you ma'am. Before we start our session, it is said that nothing comes before the blessings from the Almighty. Therefore, I would like to request all our dignitaries to come for lamp lighting. Thank you, sir. Moving forward, I would now like to request Dr. Hemant Malhotra, sir, to kindly come on stage to felicitate our chief guest, Dr. M.L. Swarankar, sir. Thank you, sir. I would now like to request Dr. Puneet Rijwani, sir, to come on stage to felicitate our special guest, Dr. Sudhir Sachdev, sir. Thank you, sir. I would now like to request Dr. Avnish Bharadwaj, sir, to come on stage to felicitate our special guest, Dr. G.N. Saxena, sir. Thank you, sir. I would now request Dr. V.K. Jain, sir, to come on stage to felicitate Dr. Swati Garg, ma'am. I would now request Dr. R.K. Surekha, sir, to come on stage to felicitate our international speaker, Dr. Prapagaran Narayanan, sir. I would now request Dr. Tarun Ojha, sir, to felicitate our special guest, our international speaker, Dr. Prapagaran Narayanan, sir. I would now request Dr. Manisha Nijhawan, ma'am, to come and felicitate our international speaker, Dr. Prepageran Narayanan, sir. I would now request our chief guest, Dr. M.L. Swarankar, sir, to felicitate Dr. Prapagaran Narayanan, sir, with a shawl and a bouquet. Thank you, sir. Now I request our head of the department, Dr. Tarun Ojha, to give us the briefing on the session and walk us through the entire program. Thank you.
Namaskar. Respected Dr. M.L. Swarankar, sir, our esteemed guest faculty, Dr. Prepageran, Professor Prapagaran Narayanan, our senior faculty present over here, friends and students. I wish to extend a warm welcome to all present here who have taken their precious time out to attend this international speaker program organized by Department of ENT. The management of Mahatma Gandhi Medical College, Mahatma Gandhi Medical University of MGMST, in keeping the vision of chairperson, believes in academic education, for which every department of the hospital and institute continuously organizes such workshop, and to keep the lamp burning, the Department of ENT is also committed for the same. We had organized last month a live hybrid surgical workup, ischemic or hemorrhagic strokes, particularly involving the cerebellum or vertebrobasilar system. Other more serious central causes include tumors, particularly those arising from the cerebellopontine angle like brainstem glioma, medulloblastoma and a vestibular schwannoma, which can lead to sensorineural hearing loss as well as vertiginous symptoms. Vestibular migraine are a common central cause of vertigo. Finally, multiple sclerosis has been associated with both central and peripheral causes of vertigo. Here we have a rather humongous list of differentials, but the most common cause is peripheral, and amongst peripheral, the most common cause is BPPV, that is benign paroxysmal vertigo. Therefore, we are here to benign paroxysmal positional vertigo. Therefore, we are here to listen and learn from the master of this field, himself, Dr. Professor Prapagaran Narayanan. Now, I would like to brief CV of Professor Prapagaran, who is an international faculty in the Department of Otorhinolaryngology as Faculty of Medicine in University of Malaya, Kuala Lumpur, Malaysia. When we first received the CV, we were left stunned because that itself was a 30-page mini booklet. So we thought, let's summarize it a little, that we realized that was the summary of main CV, the 30 pages. Therefore, I would like to excuse myself from reading all of that because it would be past dinner by then. I will let the main man himself talk, his aura, as his reputation precedes him by continents, if I may say. Nonetheless, to brief you a little, Professor Prapagaran Narayanan is currently Senior Professor and Consultant in the Department of Otorhinolaryngology, Head Neck Surgery at University of Malaya. He was the Chairman of National Otorhinolaryngology and Head Neck Surgery Specialty Training Board in 2012 and 13. He was also President for the Malaysian Society of Otorhinolaryngology and Head and Neck Surgery for 2013 and 14. He is also the President of the Asian Research Symptoms in Symposium in Rhinology 2016. He is also a member of International Advisory Board of Rhino World, Asia Pacific Cochlear Implant and Related Science, the International Academic Conference of Otorhinolaryngology, and the World Council of Endoscopic Surgery of Skull Base and Brain. He was the president of the 9th World Congress of Endoscopic Surgery of Skull Base, Brain and Spine in 2020. He is the author of more than 20 textbooks, including DVD electronic manuals and more than 180 papers published in local and international journals, including the prestigious New England Journal of Medicine, and has numerous surgical video demonstrations to his credit. He is currently part of the editorial board and reviewer of more than 15 journals, local and international. He is also a sought after speaker and presenter in his area of expertise and has been invited to more than 250 conferences in the Asia Pacific region and across the world, and has made more than 600 lecture presentations. So, so before inviting Dr. Prepageran, I would invite Dr. Vikas Swarankar sir to say a few words of blessings to us. Thank you.
Good afternoon, dear friends and students. First of all, it is my pleasure and honor to welcome Dr. Prapagaran Narayanan to our university. Sir, we are greatly obliged by your presence. Dr. Tarun Ojha, our head of the ENT, has already briefed your biodata. I have also gone through the letter of invitation, and I see lot of your degrees, FRCS from different places, and you are one of the very celebrated authority in ENT and head and neck surgery, not only in Malaysia, not only in the University of Malaya, which is the oldest university of Malaysia, but all over the world. So we are really proud to have you here, and today you are going to discuss one of the very important topic about this proximal benign positional vertigo, which is quite common also. Even I have suffered on few occasions because of this, and I am quite sure that many of those who are in the 50s, 60s or 70s might have experienced this positional vertigo for some time or other, and it is not very unusual. Sometimes you get and you just take Vertin or some other tablets and get all right with bed rest and some positional changes. But yes, it is a matter of concern for all of us. And most important thing is to what we are doing in our daily clinical practice, whether it is a field of gynecology or oncology or neurology or cardiology or ENT, otorhinolaryngology, or any branch for that matter. We go for the quantity cutting and getting the skills. We do not go deep into the anatomy and physiology, basic aspects of medicine, in which our subjects you are studying, you are taking the training. Because unless you know the anatomy, unless you know the you have the fundamentals, three-dimensional thinking of your brain, of your mind about your subject, like here is the inner ear. So you should know what is the anatomy of the inner ear, what is the vascular supply, blood supply, I mean venous supply, arterial supply, lymph supply, what is endolymph, what are the different structures in the inner ear, what are the structures in the middle ear. All of this you have to know. And you should know the physiology also. You should know the pathophysiology also. Recently, I will not go into detail, is the subject matter of Professor Narayanan, but what I wish to say to all students, all trainees here, that kindly focus on basic academic background. Very strong, it should be very strong. Your genetics, your embryology, your immunology, your knowledge of anatomy and physiology of that particular organ should be very, very solid, so that you can treat and you can unnecessarily avoid the test. Again, here one of the example, this vertigo, where our old clinician saying comes in the picture. That is the history taking in physical examination. By just taking history, by doing the physical examination, by following the philosophy of exclusion of the diagnosis, you can come to the conclusion, or you can narrow down the diagnosis, and you can avoid unnecessary expensive tests like MRI, CT scan and other things. So recently, when this medical education team came from the National Medical Commissions, one of the doctor, he said very good thing. Sa vidya ya vimuktaye. Knowledge is that which leads to liberation, which leads to freedom. That is the knowledge. ये विष्णु पुराण का श्लोक है. वो कर्म जो आपको बांध न सके, यत कर्म न बंधते. जो भगवत गीता में भगवान कृष्ण ने बोला है, कर्मण्यवाद का रस्ते माँ फलेषु कदाचन. यदि आप ऐसा कोई कर्म कर रहे हो, आप रिपीटेड सर्जरी किए जा सकते हो, तो यू कैन बी स्किल्ड टेक्नीशियन, यू कैन बी स्किल्ड सर्जन, you can get little bit name also, but the fame which Dr. Narayanan has got is because of a strong background. And once you have a strong background, you have the quality, then you go for the quantity, then you go for surgical, as much volume as possible, but knowing the fundamentals. So knowledge which leads to the freedom, liberate in the, I am talking in the worldly affairs. It is both true for the spiritual affairs and worldly affairs, both. But here I am talking in the context of especially the ENT surgery. If you know the anatomy, if you know the background, if your academics are good, you will be able to do whether it is a mastectomy or tonsillectomy or some skull-based surgery or removal of some tumor or transsphenodal or anything, that will be possible only once you know the basic background. So my request to all the students sitting here is to pay kind attention, strong attention for the studies of the basic things, basic sciences, and then build up over that your clinical skills. With these words, I once again welcome Dr. Prapagaran Narayanan. Incidentally, I was just talking to him. His family moved from India, so he's the fourth generation in Malaysia. So we are happy that person from the Indian origin is now a luminary in the field of otolaryngology. Once again, we welcome you, sir. Thanks a lot.
Thank you, sir. Now I would request all our dignitaries to kindly take their seat on the front row. With that, I would like to invite our international speaker, Dr. Prapagaran Narayanan, sir, to kindly start the topic. Thank you.
Namaskar. Thank you very much for the very kind invitation. The Honorable Dr. Swarankar, the Emeritus Chairperson, the Dean, the Vice Chancellor, thank you so much for the invitation. It's both an honor and a privilege to be here. My great-grandparents left India many years ago, and it's the first time I came to India, and the plane landed, and I came out of the airport in Chennai, and I saw a big statue of Ganesha. I had tears in my eyes because I was back home. So it's always a pleasure to be back in India. You can take us out of India, but you can never take the India that is inside us. So thank you for having me here. I would like to speak on vertigo, a general concept of vertigo. Is it possible to off the lights in front, if possible? Okay. So this is a picture that was taken 20 years ago when I was a fellow in Toronto. This is John Rutger, the man who, one of the world authorities in vertigo, and this was during my fellowship. And I would like to think that although 20 years has passed, I look more or less the same, maybe 7 kilograms more, a little bit less hair. But what is amazing, how fast your hair flies with the passage of time as well. That's one of the testaments. And here is Andy Scott, one of my colleagues, and you will see his picture and the video afterwards, because we did a collection of eye movements, nystagmus, which is now being used quite extensively as a teaching tool around the region. Why is it that people don't like to see vertigo patients? If you give any resident a case of vertigo, you can see they start having nystagmus as well. It's not something that people like to see, and I can see people smiling in the background. And if you look at the Harrison's textbook of medicine, the number of differential diagnoses is enough to make you collapse. It goes to pages. But what is more important is there's always this fear that we're going to miss a central symptoms. There's a fear that one day we're going to give him some medicine and send him back, and he's going to come back 6 months later with an MRI scan with a brain tumor. And he says, see, I came 6 months ago, you missed a brain tumor. There's also this notion that there's little we can do with patients with dizziness. Well, all we can do is give some beta-histidine and vestibular rehab. There's nothing much we can do. But sometimes, at the very least we can do is just to listen. Because especially in this equilibrium of the aging, as people get older, sometimes all we need to do is just listen. Because sometimes we just need to talk. And it's not very long from now that we will be sitting on the other side of the table as the patient as well. And now we have a lot of technology. The problem is over-dependence on technology for results and diagnosis causes us to lose clinical acumen and human touch. Now we look at the scans, images, and diagnose based on the images, and sometimes don't even touch the patient. And that is, I think, one of the biggest downfalls of what we have. No matter how much technology you use, you cannot let go your clinical acumen. And as far as vertigo is concerned, more than 90% of the cases can easily be managed clinically without a price of vertigo. So we use technology only for fine movements, for medical legal cases, for compensation cases, but for everything else we use just simple clinical. And one of the other things that happens now is that we tend to focus on something rare, focus a lot on that and forget the bigger picture. So it's very important that we have a bigger picture of the whole thing instead of just focusing into something that is small. Is it possible to off this light? Is it possible? If it's not, it's okay. The videos will be much clearer. So why is dizziness a problem for the patient? Simply because there are a lot of misinformation. And one of the other problems is there is a new doctor in town. He works for free. He's available 24 hours a day. He works for 7 days a week. He's extremely popular. And his degree, he's recognized and licensed worldwide. And patients swear by him. And his name is Dr. Google. So now more and more patients turn towards Dr. Google and come with printouts of Google as well. So it's very important that we get our foundation strong so that we are able to counter what this very famous doctor who's available 24 hours says. It's very important that our basis is very strong as well. Let's forget about everything that you've learned about vertigo and let's reflect back what is balance. Now if you look and imagine that the inner ear is fully formed in a 2-month-old gestational baby. That means when a fetus is only 2 months old, the inner ear is almost full adult size. It's unbelievable. How is it possible that God made a simple sense organ a full adult size? So when we do a cochlear implant, whether you do in a child or you do in an adult, the implant is the same because the inner ear and the cochlea is a full adult size in a child. Now if you think about the fact that you need the inner ear to give you a 3-dimensional view, a 3-dimensional ability in the space itself, it makes sense. because the fetus is floating inside a bag of water and it's dark. There is no light, there's no switch bulb inside the uterus. And the fetus is floating in water with an umbilical cord. So therefore, if they are not able to have a sense of balance, a sense of three-dimensional space, they will easily have the cord around their neck. And the incidence of cord around the neck is very small, simply because the inner ear is fully formed by the time the fetus is 2 months old. And if you look at a child loves to be dizzy. You put him on a swing, they want to be swung more and more and more. When they go in circles and spin and spin and spin, and they're so happy to be dizzy. Why is that? Because when a child is born, the concept of balance is zero. That means their brain has got no concept of balance at all. The more movement the child makes goes into the brain as this is normal movement. So the more the child gets dizzy, the more the child moves, the brain records it as normal. So the more exposure the child has got, the more normal it becomes. Now that is very important, because if you see the world famous ballerinas, if you see the acrobats, they are all people who have trained from young, because the sense of balance is very important as well. And this also points to the fact that why some people tend to get car sick and some people don't. So some of the patients I've seen are air stewardess, that they fly for the first time and they get dizzy. And without fail, if you ask them, they always come from the flat part of Malaysia, where they have not traveled up or down the hills. They have never flown before. So when they fly for the first time, the input that the inner ear gets is an input that they've never been exposed to before. So whenever the input that comes to the inner ear is not part of what is already saved, the brain interprets as vertigo. Okay? So the fact is, you should let your child get dizzy as much as possible. Swing them, let them go on roller coaster. Then they can have a wonderful vestibular system. And one of the examples I give is that when Malaysia sent the first astronaut, the last deciding factor was when they put everybody into a rotational chair. And they spun everyone, or four of them, the final candidates, very quickly. And only one person was still awake. All the others were knocked out. And that one person became the astronaut, simply because of his inner ear. Because you need to be able to not pass out based on the moving. But your proprioception, your body is saying, no, I'm not moving. That mismatch that goes into the brain interprets it as vertigo. But if someone has been in the car as a child and goes through all the hills, all the mountains, and they're so used to being on a car, that input that the inner ear gives, they are used to, they're doing a car sick. So if you want your child to be a Formula 1 car racer, put him in a car, go fast, brake, so that his inner ear gets used to all this movement and he will not get car sick. Basically, the entire balance is like this. It's how a team of athletes row. Each one of them will row with the same speed, same movement, and same stamina. But what will happen if, for example, this lady here, if her left hand becomes cramped, then what happens is the boat will not go straight. They will start to swerve because all the others are moving normally. So that is vertigo, simply because the input is abnormal. To compensate this, all the others will have to modify the way they row so that they can come back to normal again. That period is vestibular compensation. So the cure for vertigo is not just the medication, but the fact that the brain will compensate. So when someone has got a vertigo, after the dizziness, he tends to be imbalanced. But we'll make him do the exercise again and again and again. And then the brain will start interpreting and say, wait a minute, I'm getting the same input again and again. This must be normal. Then the brain will save it under the file as normal. With that, the vertigo comes down on time. That's vestibular compensation. Simple. That is the entire concept of vertigo, and you might not even find some of this in textbooks. So what are the vestibular pathways? Basically, vestibular ocular. So we know that the inner ear, the concept of the inner ear is to have a three-dimensional ability. Vestibular ocular means the eyes moves with the head. That means when someone calls you from the back and you move your head, the eyes will also move with your head. Otherwise, your head will move, your eyes will still be looking here. You have to knock your eyes to bring it to the other side. And the vestibular ocular reflex is one of the fastest reflex in the body. It's so fast that only now we're able to measure. So now we've got the eyes that is moving with the head. But the rest of the body must move with the head as well. Otherwise, there will not be synergy during movement. So that is the vestibulospinal tract, which means the rest of the body moves with the head as well. So, eyes moving with the head is not enough. The head moving with the body is not enough. We must be able to do fine movements, like a simple thing, tying a shoelace, for example. All these are fine movement, and this is controlled by a vestibular cerebellar tract. So the way to examine this, when we examine vertigo, is to go layer by layer or step by step of the tracts. How do we manage vertigo patients? Now in clinic, when someone comes and tells you that they are dizzy, what you need to do is just ask them, can you please describe what you mean by dizzy? Just keep quiet. Don't say a word. Don't lead them by saying, is the room spinning? Is the room rocking? Is the room moving? Just keep quiet, because you do not want to plant ideas into their head. Let them describe the dizziness themselves. If they say something like, if they say something to the effect of, I feel everything getting dark. When I get up too fast, it gets dark. Then it may be orthostatic. If they say something that whenever I take my medication, I get a bit of imbalance, then you know it's drug-induced. Or if they say something inside my head is moving, something is not right, that's not a true vertigo. That's not an inner ear vertigo. And all of us get this. You get a letter from the income tax, you will get this kind of dizziness as well. Whereas a true vertigo is when the room is spinning or the room is rocking and you feel you are completely imbalanced with surrounding. That is true vertigo. And once you have established the person has got a true vertigo, which is the room spinning, the room rocking, then all we need to do to differentiate between a central component and a ear or the vestibular component is to ask them whether they have any central symptoms, like visual changes, numbness, altered sensorium. And if they have this, then what we need to do is do an MRI scan. Whereas, if they do not have any of the central symptoms, then what we do is we ask them whether they have the dizziness is associated with hearing loss, pressure, and tinnitus. If it is, it's Menial Disease, and if it comes with positions, it's BPPV. If it's episodes of spinning that happens for a few days, that's vestibular neuronitis. But if it's only spinning without any ear symptoms, it's vestibulopathy. So this is how we divide the inner ear itself. Now this is a very important slide. So those of you who want to know the inner ear and how to differentiate, this is the picture that you take. This tells you the diagnosis, and all you need to do is to find out the duration of the vertigo and whether there are any ear symptoms that come with it. So if you have vertigo more than 20 minutes that comes with any ear symptoms, hearing loss, pressure, tinnitus, that's Benign disease. That comes with positional and seconds, that's BPPV. So with this, we are able to subdivide in a very easy, systematic manner what is the most likely diagnosis. This is a slide from Toronto in the year 2002 when I was there. This is after 1,000 patients that were seen in a multidisciplinary clinic. 65% were vestibular. Central was only 7.1. But what is more interesting is 8.3 psychogenic was actually higher than central, and the unknown cause of vertigo was actually higher than central as well. This is the slide from my own institution, and you will find that Menial disease is very low. That is simply because Menial disease is an autoimmune. So everyone likes to diagnose patients with Menial disease. But actually Menial disease is extremely rare in our part of the world because it's autoimmune, and autoimmune is almost exclusively part of the Western culture or Western disease population as well. Let's look at vestibular ocular reflex. Now, vestibular ocular reflex is the easiest way for us to examine a vertigo patient. No matter what the patient says, look into the eyes, and the eyes will never lie to you. So these are the structures that is required for a vestibular ocular reflex, and these are the tests that you can do to assess whether the patient has got a intact vestibular system. Now, I'll go through one by one. The first test is a head shake test. What we do is we hold the patient's head and we shake his head 40 times or 20 seconds. More than that, the head will come out in your hand. So 40 times is more than enough. What this does, it stimulates both the inner ear at the same time. Remember the rowing picture I showed you just now? If both the inner ears are equal, both of the inner ears are exactly the same, the eyes will look straight ahead. The vestibular ocular reflex on either side will cancel each other. However, if one side is lower than the other, then we will have nystagmus. This is probably the easiest way for you to diagnose vestibulopathy. If you get called to a medical ward, a patient on gentamicin or IV antibiotics, and he complains of dizziness, how do you know the patient has got a bilateral vestibular loss because of aminoglycosides? Let's do a test. Can you all read this line? Can you read this? PECFD, correct? Now, can you shake your head like this and continue reading? Okay. If your vestibule is intact and your eye moves with your head, you should still be able to see PECFD. If you cannot and you start missing line, the head of ENT is just here. Please see him as soon as possible. It indicates that you have already lost vestibular function. So this is an easy way for you to find out whether someone has got a bilateral vestibular loss, even if the patient is bedridden, even the patient is bedbound in the medical ward. This is how an oscillopsia looks like. For the patient, everything is moving, and this is how oscillopsia looks like in a vertical component. Everything is moving up and down as they walk. Bilateral vestibular loss. So high frequency head thrust maneuver. This is probably the single most important test, and I'll show you in videos again how to do it. That was vestibular ocular reflex. How about, that is the movement of the eye in relation to the head. How about the movement of the head in relation to the body? We do a gait examination. Now, so this is Romberg. Close the eyes and see whether you're able to stand straight. The next step is tandem. Heel to toe, very slowly. Even patients who's got vestibular loss can do this very fast, but very slowly is very difficult to do. This is what the police use when they catch you for drunk driving as well, right? Yeah? The same in India as well. The police are all the same everywhere. They have their own academy, I think. So this is how you know someone is malingering. So this is called a Chinese acrobatic act. Look at how he's going all over the place. But look at his feet. No matter how he pretends he is falling, he's imbalanced, his feet is steady. This is how we detect malingerers. Patients who sway all over, but the feet is perfect. The Chinese acrobatic act. All right? How do we assess now fine movements? This is vestibular cerebellar tract. Touch the finger, touch the nose, touch the finger. And you must make sure the hand is stretched. Only then you will have the intentional tremors. Otherwise, you will not catch it. Then we ask the patient to alternate the hand movement, and you will find that they are not able to do. All these are tests of the vestibular cerebral tract. Again, you can see how she's losing some steps as well. The last test is the ability to draw circles in the hand. So if you think this is bad, wait until the other side. See, it's a triangle. We are asking her to draw a circle, but what she's drawing instead is a triangle. So this is how we detect vestibulocerebral tract deficiency. And again, if you have a bilateral vestibular loss, IV gentamicin toxicity, then the vestibulocerebral tract is affected, and they start walking with an ataxic gait, exactly like how a 9-month-old baby walks. So this is how we assess clinically which tract is involved and what is the cause of vertigo. Now, how do we differentiate a peripheral vertigo than a central vertigo? That's the problem that we have. That's what we are worried about. Very straightforward. All you need to remember is if someone has got a acute vestibular syndrome or a peripheral vertigo, they will be dizzy. They'll have nausea, they'll have vomiting, they won't be able to walk, and they will have nystagmus. So if someone comes to you with a nystagmus, but they don't have acute nausea or vomiting, then it's most likely central. But what is more important is look in the eye, because the eyes will tell you whether it's peripheral or central. A peripheral vertigo will always have a biphasic nystagmus, which is a fast phase and a slow phase. Fast phase, slow phase. So horizontal plane, biphasic. A slow phase and a fast phase, with the only exception in BPPV where you have a rotatory nystagmus. Let's talk about nystagmus. Now, in a normal patient, or all of us for example, both the inner ears push the eyes medially. So if both the right and left push the eyes medially, if both of them are working well, we will be able to see straight ahead. That's what happens to all of us. But if for any reason the left side is affected, as you can see here, then obviously the right side is stronger and the eyes will start drifting to the left. That is the slow phase. Now the body will compensate by correcting it. That is the fast phase. So we always name nystagmus based on the fast phase because our eyes is more attuned to looking at fast movements. The same way, in a hypervestibular disease, which is very rare, a viral labyrinthitis for example, on the left side it becomes more input. Therefore, the slow phase will push towards the opposite side and the fast phase will come back to the same side. So this comes down to the key points. If you have a biphasic horizontal nystagmus, if you have a vestibular function that is lost, the direction of the fast phase is always away from the lesion. And a hyperfunction, which is extremely rare, is towards the eye, towards the affected side as well. But some patients have got congenital nystagmus. This is an example of someone who's got a congenital nystagmus. And the congenital nystagmus is like a pendular clock. They go like the eye. They swing like an eye movement. Another example of a child with a congenital nystagmus. Can you see the eyes are moving like a pendular clock? The best thing about this, the diagnosis is very easy. Simply because the patient themselves will tell you, I've had it since I was small. The same way, and look at this another example. A rotational pendular movement. There is no fast phase, there is no slow phase, and these patients will tell you straight away that they had it since small, and most of them are not able to complete school because they are not able to read. The eyes do not stay in the same place for them to read. But they ride motorbike, they have a family, but they are not able to excel academically, unfortunately. How about fistula tests? This is when there is a presence or an opening into the labyrinth, and when we put a pressure into the ear, the pressure goes into the labyrinth and causes nystagmus like this. This is called a fistula test that is positive. This indicates that there is another opening inside the inner ear itself. Then when we explore the mastoid, we identify the defect, we plug the defect, and subsequently after surgery, you see the nystagmus goes away completely. Again, peripheral nystagmus is a horizontal biphasic nystagmus with slow and a fast phase. Let's look at this now. This is a patient who's looking to the right. And can you see the patient has got horizontal biphasic nystagmus? The direction of the fast phase is to her own right. So this is a peripheral vertigo. Let's look at this video. She's looking to the left. Can you see the direction of the fast phase is to her left? And when they look to the left, or the direction of the fast phase, the nystagmus gets amplified. The same way, when she looks to the opposite side, in the direction of the flow phase, there is no nystagmus. So, biphasic horizontal nystagmus that gets amplified in the direction of the fast phase is a pathognomic for a peripheral vestibular loss. Look at this eye movement now. In all vestibular disease, both eyes move at the same time. But if you look at hers, this eye is moving. This is not. This is central. This is disconjugate movement. When you have one eye moving and the other is not, it's always a disconjugate movement. How do we examine vestibular ocular reflex? This is Andy Scott, my colleague that I showed you in the photo just now. So what you need to do first of all is be able to see what is normal. So this is smooth pursuit. The ability of the eye to move horizontally, smoothly, is called a smooth pursuit. And now there's a vertical up and down. You can see the eyes is moving smoothly, and we all do this. You're walking with your spouse in a mall, and someone attractive comes along. You're still looking straight, but your eyes will move to the side. Correct? All of us do that, yeah? I can see all the guys smiling, so I know you are just like me then. Saccades is when you look at one side, and then you look to the other side. That is saccade. Again, you will find the eyes move smoothly. There is no saccadic movement. But most importantly is the Halmage Maneuver. And let me show you how the Halmage Maneuver is done. You turn the patient's head and very quickly turn the head towards you. Can you see the eyes is always looking at you no matter how fast you turn the head? This is Halmage Maneuver. This is the one test that you need to master, and if you master this, you'll be able to pick up peripheral vertigo very, very easily as well. This is a colleague of mine who's got a very big eye, so I used her eyes to show the examination. Fixation, convergence and divergence, that is smooth pursuit. You can see how the eye is able to move smoothly without any stop. That is a normal smooth pursuit. This is vertical smooth pursuit, and now she's going to look from one direction point to another point, one point to another point. So this is again a normal saccade examination. So is it possible that a normal Halmage is able to pick up high frequency loss? Look, this is a normal Halmage maneuver, and now let's look at someone who's got an abnormal maneuver. Can you see? Did you see how the eye movement is a bit slow? Let's do one more time. Yeah? Look at the eye. Can you see how the head moves first? Only then the eyes move. So this is how we are able to identify the Halmage maneuver. This is again my mentor, John Watka, and you can see how an intact vestibular ocular reflex, no matter how quickly you move the head, the eyes is always looking straight ahead. This is a normal eye movement. Now let's look at an abnormal eye movement. Do you see that? The split second where the eyes is left behind before the eye catches up again. There, one more time. This is how we know that the patient has got a high frequency vestibular loss. And which ear is affected is the direction of the head turn itself. This is head shake nystagmus, the one I was explaining to you just now. So after shaking the head, if both the inner ears are intact and are equal, the eyes will be looking straight ahead. But if it is not equal, then you will have peripheral nystagmus like this. This is how we know whether there is a balance loss in the ear. And these are all simple clinical tests. And look at this gentleman. He's doing his own head shake. And can you see his eye moving? You will not get this unless you have a vestibular loss on one side. When you shake your head quickly, you're stimulating both your ears at the same time. If both your ears are functioning normally, Your eyes will look straight ahead. You will only get this when one inner ear is not functioning. So this is how, with simple clinical examination, you're able to determine whether there's a balance loss, a peripheral vestibular loss, and which side it is. How about central vertigo? What is the characteristic of the nystagmus for central vertigo? So as long as it's not a biphasic horizontal nystagmus, which I showed you just now, it means it's central. So these are the different types. And this is the classic example of down beating. Can you see the eyes is going down, beating like that? And this is very easy to see. When a patient comes out of OT, before it's completely reversed, if you look at his eyes, he'll have down beating. These are all central nystagmus or central vertigo. Can you see how the eyes is beating down? So this is someone who's got a torsional down beating. So the head is pointed backwards. This is magnified by a lens, and you can see now there's a torsional down beating. So remember, for a peripheral vertigo is always a biphasic horizontal nystagmus. Gaze nystagmus. When you have a nystagmus, when you see to a side, it's quite normal to have a few beats. But if it's sustained like this, then it's central. So a sustained gaze nystagmus is central. Next is we're going to ask her to hold a camera, and then we're going to swing her. So as you move, if your central component is intact, the vertigo or the nystagmus will be suppressed. But in her case, because she's got a central component, can you see the eyes moving? Because there is a central component and she's not able to suppress the nystagmus. She will do very well in one of the horror movies. This is the kind of eyes that you want in horror movies. So this is a central nystagmus as well. This is monoocular gaze nystagmus. What it means is, now there's no nystagmus, but the minute that we close one of the eye, the nystagmus starts. So all these are examples of central nystagmus. All you need to know is, remember, for a peripheral, it's a biphasic horizontal, except for BPPV, that is rotational geotrophic. Everything else is central. This is a patient who's got a microsaccadic oscillation, which means that he's not able to fix. You ask him to look at one point, his eyes is not steady, he's always moving. The saying goes, do not trust someone with a shifty eyes, right? But in this case, he's got a central component. His eyes is not able to fix. All these are examples of central. This is flutter. Can you see how the eyes is making a jiggle? So all these videos were part of the project that I did 20 years ago during my fellowship. And this is being used for teaching all over. And it's been 20 years, I have changed, but the nystagmus and the relevance is the same. The clinical medicine, the basics, anatomy, physiology will always be the same, no matter how much changes there are to clinical medicine. This is someone who has got a intranuclear ophthalmoplegia. Usually both eyes will always move the same. But in a case like this, you can see that one eye is moving, the other is not, in a disconjugate eye movement. So these are examples of intranuclear ophthalmoplegia, and again, these are also examples of central as well. Direction changing nystagmus. In a peripheral vertigo, the direction of the nystagmus is always in one direction. However, if the fast phase, the direction of the fast phase changes. So in this case, you will see the direction of the fast phase is to the patient's left. So you may think the patient has got a peripheral nystagmus because this is how it looks like. But when they roll the patient to the opposite side, classically is going to the patient's left. Now when we turn to the patient the other side, it's still beating to the left, stopping, and now it's beating to the right. Did you see how the direction of the nystagmus has changed? So this is a classical direction changing nystagmus, and this is central. Right? This is a child who is born with a agenesis of the cerebellum. And again, if you look, remember the smooth pursuit? If you look at his eyes, he's got a gaze nystagmus, which is worse. And look at that. His eyes does not move smoothly. So this is central. When you're not able to fix, when you're not able to move your eyes smoothly, that is central nystagmus. So this is purely because he was born without one cerebellum that is intact. This is someone who's got a positional nystagmus, and he's got a surgery done for intracranial lesions. I'll go a bit quickly. So again, after the surgery is done, you can see the nystagmus that he has. So you can see how the nystagmus, downbeating nystagmus, as you can see here. Now this is a very nice nystagmus that's called a cross coupling. There's no spontaneous nystagmus, but after a while, if you look at the eyes, it causes a cross. So if you do a head shake movement, you should have a biphasic horizontal. But look at the eyes. It's beating like a cross, like an X. So this is called a cross coupling. So this is my favorite nystagmus. So if any one of you can mimic this, I'll pay for lunch today. Look at this. Look at how the eyes is moving. This gentleman was from Peru, I remember. He had a massive stroke after SBE, subbacterial endocarditis. Again, if you can see, this is like a seesaw. One eye goes up, one eye goes down. A typical seesaw nystagmus, very difficult to see. So again, whenever you are faced with patients with vertigo, don't just depend on the history. Look at the eyes. The eyes will never lie. Now, some causes of vertigo are man-made. This is a nurse who had a ear swinging performed by one of her colleagues. And immediately after ear swinging, she had a facial nerve palsy and a severe vertigo, simply because her colleague forgot to screw the cap properly. So when they injected quickly, this metal piece just flew straight into the ear, hit the tympanic membrane, dislocated the ossicles, injured the facial nerve, and went straight into the inner ear. A simple mistake, not screwing properly. The patient has got a total dead ear and a facial nerve palsy as well. So now, clinical questions. We know that the hearing has got low frequency and high frequency. Is it possible that the vestibular system has got the same? So this was the project that I did during my fellowship, and we discovered a new clinical entity. We discovered that the balance has got a high frequency and low frequency, and that became the basis for all the tests that's being done now. And so what we did was we used a magnetic chamber to measure the minute details of the eye movement. So by putting a scleral coil made with metal, we were able to measure minute movements of the eye inside a magnetic scleral coil. Now remember, this was 1 million Canadian even in the year 2002. But what it does is it gives you, no matter how quickly the head is being moved, the eyes moves with the head. This is normal. Look at someone who's got a unilateral nystagmus on this side. So on the left side, no matter how quickly she moves on the left side, the eyes follows the head. Whereas on the right side, because she's a balance loss, when she moves very quickly to the right side, the eyes does not follow the head. This is someone who's got a bilateral vestibular loss. In the same way, we are able to understand why not all patients actually recover or compensate because of vestibular loss. Because whenever you have an inner ear that is fluctuating, you cannot have vestibular compensation. And this is how we measure the otolith and the saccular functions as well. So let's talk now about acute vertigo. So what do you do when you know the patient has got an acute vertigo of a peripheral in origin? The patient will have nausea, the patient will have vomiting. So the first thing you want to do is to stop the nausea and vomiting by giving a vestibular suppressant, like Maxolon or Stugeron, something, or Dramamine, something that will suppress it. But after that, you must allow vestibular compensation to occur. And for vestibular compensation to occur, you must stop the vestibular sedatives in 1 to 2 days, especially in older people. Because in older people, the amount of input or the output that comes from the inner ear is very minimal. If you suppress whatever that is left, they will never recover. You must always allow vestibular compensation to occur by giving a beta histidine after the first 2 days of vestibular sedatives. It's very important that we allow vestibular compensation to occur. That means we give only 1 or 2 days of antiemetics or acute medicines and stop and allow vestibular compensation to occur with beta histidine and vestibular compensation. So this is the absolute treatment for vertigo itself, vestibular compensation. And the only way is to make sure that we do not use vestibular sedatives for more than 2 days. So again, if this young lady's hands are clamped on the right side, which means you've got an infection or Menial disease, you need to allow the other parts or the other people to modify the way they row so that the boat goes straight. That modification takes sometimes 2 to 3 months. But if you use beta histidine in vestibular rehab, that modification occurs much faster. So these are managements of recurrent vestibulopathy. Patients with vertigo without any ear symptoms is very common. Beta histidine and vestibular rehabilitation. Someone who's got vestibular pneumonitis, acute dizziness that lasts for 2 to 3 days. If they have nausea and vomiting, we admit them. We give them vestibular sedatives for 2 to 3 days. And almost all of them will have some amount of residual imbalance with fast movement as well. Menial disease, I think most of you are quite familiar with this. Those who have rooms spinning for around 20 minutes to 24 hours, but they always have ear symptoms, hearing loss, tinnitus or pressure, and the diagnosis is easily made by an audiogram of low pressure, endolymphatic high drops, and this is easily treated now by a high dose beta histidine. We used to do gentamicin, intratympanic, but all that now we do not require anymore because of high dose beta histidine. BPPV, the commonest cause of vertigo. So the pathology of BPPV is basically loose crystals in the inner ear, and as the head moves, the crystals move, causing imbalance. And this is how a Dix-Halmage maneuver is done. When you put the head in a head down position, you will see a geotrophic nystagmus. So this is the only time where a peripheral vestibular dysfunction comes with a non-biphasic horizontal nystagmus. So how do we manage this? We manage this with an Epley's maneuver, where you want to put back the crystals to the safe place. And there are 3 different steps to it, and each step we do it for 20 seconds. So a properly done or performed BPPV or Epley's maneuver will cure more than 80 to 90% of Epley's maneuver. And I'll show you the video on how it's done. So what we need to do is, first of all, put the patient's head down, explain to the patient what we are going to do, put the patient's head down in a right, in this case right hanging position, and the minute when the head comes down, you will see after a lag phase a geotrophic nystagmus. This means that the crystals that are inside the ear canals are moving. So in this movement, when the head goes down, the crystal is moving, as you can see. We need to wait until the crystals stop moving. That means wait until the nystagmus stops and the patient says there's no more dizziness. And then you turn the patient to the other side. She will have nystagmus again. This is because the crystals now are also moving. You have to wait until the nystagmus stops, because it means that the crystal has moved and they have stopped moving. If you go to the next step before the nystagmus stops, the crystals will go back to the original position and the entire procedure is gone. So this entire procedure actually takes almost 2 to 3 minutes. If it's done properly, the results are very, very good. So now I do this maneuver for the patients. I ask them to bring their spouse, and I teach their spouses what to do. And now the spouses do on their own at home whenever there is problem. So they don't come back to see us because we are able to tell them, this is how you do it. We give them a video on how it's done, and now most of them are doing it at home. But after this maneuver, some people will have some amount of imbalance as well, because they're so used to the crystal being there. Again, you will need beta-histidine for a short duration so that the vestibular compensation takes place. So this is an example of a surgery where we're opening up the inner ear, and here now we are looking at the endolymph. So that is the crystal inside the endolymph itself. We are removing the bone around the lateral semicircular canal, the posterior semicircular canal, and again to give enough exposure. And here you can see the endolymph intact. So that is the crystal, as you can see, and that's the endolymph that is intact. If we damage this endolymph, then there's total hearing loss. So now we are able to plug this, and therefore patients do not get dizzy. So these are evidences that show the use of beta-histidine helps in patients with a BPPV. So, can we do surgery now for patients who's got BPPV? It's possible, and this is the results that I was part of, where 33 surgeries were done for patients with BPPV. There was refractory to Epley's maneuver, and we plugged it by tissue, and all of them had complete resolution. This is an example of someone who's got a superior semicircular canal dehiscent. Here, the semicircular canal is exposed here, and this is the nystagmus that the patient has got, and this is how the surgery is performed. This is the right ear, that's the lateral semicircular canal, and now what we do is we're going to drill the superior semicircular canal at the ampulated end, make sure the endolymph is intact, and then we drill the non-ampulated end, and then use some periosteum tissue to plug the superior semicircular canal. By doing this, the endolymph does not move, and the nystagmus or the vertigo is completely resolved. Again, you can see very nicely the lateral semicircular canal, the posterior semicircular canal, the facial nerve, the middle cranial fossa, and how both of them are occluded very nicely. So let me go a little bit quickly in view of time so that we can catch up. Another very important cause of vertigo is ototoxicity. So these are patients who use antibiotic ear drop, and some of the antibiotic ear drop, if they are used for a long period, can cause imbalance and dizziness. So this was a study that we did when doing part of my training, and this paper that we published changed legislation in the UK, in Canada, and France, simply because of gentamicin ear drops. Gentamicin ear drops are very effective when you have ear discharge, and patients being patients, if they pay for the ear drop, they will use every last bead of the ear drop, although they don't have discharge. And they will then, to save money, they won't come back and see you. They will go and buy from the pharmacy and continue using for 2 to 3 months when they don't need to. So it's very important for us to tell them, when you don't have discharge, stop. I've seen ototoxicity with kanamycin. I've seen ototoxicity with polymycin. The only antibiotic ear drop that I've not seen an ototoxicity is ofloxacillin. So that is the only one that does not have ototoxicity. So these are some of the papers that we have written so far over the last 6 or 7 publications that we have published over the last 1 year. I go this very quickly. And let's go to surgical management. We are all surgeons. I will just show you some videos of surgery to show you that there is a role for surgery in vertigo. At the same time, to show you the anatomy that we talk about. So this is someone on the right side. So that's lateral semicircular canal, posterior semicircular canal, superior semicircular canal, and here you can see the subarcuate region, and that's the endolymphatic sac and endolymphatic duct. You can see how the endolymphatic duct is going into the labyrinth. And this is the middle cranial fossa here. There's a jugular bulb. and that's the middle cranial fossa. There's the dura that is exposed, and there's the superior pituitary sinus, there's the sigmoid sinus. Another example of the anatomy itself. This is the right here. There's the sigmoid sinus that carries the blood from the brain. There's the transverse sinus. There's the posterior cranial fossa, the dura of the posterior cranial fossa. There's the dura of the middle cranial fossa. And here you can see how the sinodural angle, the junction where the middle cranial fossa and the posterior cranial fossa joins, and that is the endolymphatic sac, the area of endolymphatic sac. So how do we do labyrinthectomy for someone who's got vertigo? So this is an unedited video. So we use a cutting drill that is 2 to 3 millimeters. We drill the lateral semicircular canal along the axis of the lateral semicircular canal, and again that exposes the endolymph and the canal itself. Subsequently, after that, what we need to do, we're going to drill the posterior semicircular canal, follow the canals one by one. Laterals at the top, the posterior is the middle level, and then you go on to the superior semicircular canal, and with this, a labyrinthectomy can be easily performed in less than 2 minutes. Exactly like how the emeritus chairman said, it's all about anatomy, anatomy, anatomy. We all speak the same language. All the surgeons all over the world, regardless of our training and where we have done our surgery, there's one language that unites all of us, and it's called anatomy. The anatomy will not change no matter where you are. This is another example of someone who's got endolymphatic sac. Posterior semicircular canal, so posterior cranial fossa. That's the endolymphatic sac that has been opened up, and you can see the endolymphatic duct that is going in as well. So how do you manage if you accidentally open up the labyrinth during surgery? This is an example where we are going to open up the posterior semicircular canal. So if we have accidentally opened up the posterior semicircular canal like this, don't panic. First thing first, know that you've caused a problem. Then what you need to do is to identify, take a piece of tissue, make sure you don't suck on the fistula itself. Otherwise you will suck the entire endolymph, and less than 1 second the entire ear is gone. Take a piece of tissue, plug in the defect, and plug in so tight that there's no space, like how we do a samosa. You know how some samosas are so fat, filled with potatoes? The same way, it must be nice and plugged in very nicely. That will stop the movement of the endolymphatic. The patient will have some amount of tinnitus, will have some amount of imbalance for the first few days, but within 6 weeks, the balance will recover because of vestibular compensation, and the hearing will come back to normal as well. I'll show you some examples of cases. Patient who's got a cholesteatoma that is eating up into the labyrinth, as you can see here. The cholesteatoma is being removed, and here you can see the opening or the defect of the cholesteatoma itself, and all we need to do is to plug it. This is now we're doing these cases endoscopically. We are not even making an incision behind the ear. So this is a cholesteatoma that is eroding the middle ear, the attic. By using a pick, we are able to dissect and remove the cholesteatoma, and now we can do the surgery all with an endoscope. And the morbidity is so little simply because we are able to visualize the anatomy very nicely. And this is the anatomy that we get after we've opened everything. That's the chorda tympani. That's the facial nerve that is dehiscent. You can see that the incus is gone, the facial nerve that is dehiscent. And you can see how the staped foot plate is dehiscent as well. And this is the defect in the lateral semicircular canal. Can you see how large the defect is? So what we do is we use a little bit of bone wax. Make sure the bone wax is pushed in all the way to the defect, and then we cover it up with a little bit of fascia. And this is how after the defect is done. Another example. So this patient I just did a few months ago, and he rides a motorbike for a living. He drives, he supplies food. So whenever you order food, he'll come on a motorbike. And now he's got dizziness. And if you look, this is fistula test. He's pressing his ears, and you can see the nystagmus that he's got. So can you imagine someone like this driving in the rain to come and deliver food for you? It's an absolute nightmare. So when we opened up, we identified the defect in the lateral semicircular canal. And then the interesting part is you can also see a leak in the foot plate. So when I touch the foot plate here, can you see this moving? This is the concept of the third window. The entire labyrinth is open up into third window. So what we need to do is, again, by using fat, a generous amount of fat, we repair the defect adequately, and subsequently we also, you can see how there's a movement of fluid at the foot plate as well. The endolymph is also leaking from the middle ear space, and that is also closed as well by putting a bit of fat on the stapes foot plate. Last two videos, this is immediate post-op. 6 weeks later down the line, no nystagmus whatsoever. 3 months down the line, the fistula is repaired, as you can see. So now we are doing the even neurosurgical part endoscopically as well. The patient who came with vertigo, and you can see how the nerve is compressed by a cyst. So we now, instead of doing a craniotomy, we make a small opening of 2 centimeters, 2 by 2 centimeters, and then we use an endoscope and compress the brain downwards. And now we're looking at the cyst that has been opened, and all this is done endoscopic assisted through a very small opening. And once the cyst is open, you can see very nicely the 7th, 8th nerve complex. That's the 5th cranial nerve, and that's the lower cranial nerve, and that's the choroid plexus that goes into the 3rd ventricle. So the entire opening is done by a 2 centimeter opening. Another example of someone who's got an imbalance, the last video I'm going to show you, that's a cyst that is compressing the brainstem, and this is again, the surgery was done with an endoscope assisted endoscope assisted by a 2 centimeter opening at the back without avoiding a large craniotomy. Again, this is the entire cyst itself. We are now opening up the cyst by using an endoscope that gives us a very good visualization. And again, now we are able to see the 5th nerve, the ICA, the 7 and 8 complex, and again you can see the lower cranial nerves, the lower cranial nerves here. That's the lower cranial nerves with the basilar artery. Can be very nicely seen as well. So with this, I'm just going to skip all this in view of time, and I'm going to go straight to the conclusion. So this is why we need balance in our part of the world, and this is why the Westerners need balance in their part of the world. So again, take home message number 1. How do you differentiate a peripheral from central? Peripheral and acute vertigo, they will always be dizzy, and the nystagmus will always be horizontal and biphasic. Take home message number 2, in acute vertigo, always give anti-nausea, anti-vomiting only for the first 2 days. After that, allow vestibular compensation, especially in elderly. Take home message number 3, beta-histidine must be given for at least 6 weeks to 8 weeks minimum, with double the dose or the same dose without any tapering. Only then vestibular compensation can take place. Take home message number 4, how important is technology? It is important. Embrace technology, but do not lose clinical acumen. The technology may break down, the parts may get fused, there may be a blackout, but your clinical acumen will never go away. Now I'd like to end by showing you this video. I took this 2 months ago of 2 impalas in Nairobi when I was an examiner there, where 2 male impalas are fighting with each other for the female impala. So they were fighting and fighting and fighting, and not realize that the female impala left with another male. That's how life is. Sometimes we end up fighting and fighting, and we forget the important things in life. So again, life is already complicated. Let's keep work and vertigo simple. Thank you very much for your kind attention. Daniel White.
Thank you, sir, for such a wonderful talk. It was truly helped us in understanding and enhancing our basic knowledge of BPPV and vertigo in general. We feel honored by your presence within us today. I would now like to invite our Pro Vice Chancellor, the special guest of this session, Dr. G.N. Saxena sir, to add few comments on this session. Thank you.
Well, good afternoon, everybody. I must thank Dr. Narayanan for the excellent talk that he gave, and it has revived the interest. I'm sure at least 50% of the people would now be interested in some clinical medicine also. He has gone through almost all the ENT teaching in an hour's time, which is again remarkable. And of course, the last slide will be remembered forever, that you have the persons. But the clinical part of it is something that we have started missing. But I think with this lecture, some of the students and faculty members also will go back to the roots and have a look at the clinical medicine. One thing that I think has been left out as a part of vertigo is the feeling that comes when you see your question paper in the exam and you say you don't know anything, and then you have that vertigo. I don't know how that is to be treated, but then thank you again, Dr. Narayanan. Thank you.
Thank you, sir. At the very end, I would like to once again thank our international speaker, Dr. Prapagaran Narayanan sir, for such an amazing and enlightening talk. I would also like to thank all our dignitaries for sparing their very valuable time and coming and being with us today. I would also like to thank Abbott team for putting this together, and we look forward for organizing such events and mutual cooperation in the future. I now request all our dignitaries, our faculty and the residents to proceed with lunch with us today. Thank you very much for being a part of this session and being with us with the Department of ENT. Thank you.